go to Kim Greenwood in Canada and ask for your comments. Thank you.
As mentioned, can you hear me?
Yes, we can now.
Okay. Greetings, everyone. My name is Kim Greenwood. I am the Director of Clinical Engineering at the Children's Hospital of Eastern Ontario in Ottawa, Ontario, Canada. A medium-sized children's acute care children's hospital. Next. Back when I started here in the late 90s, myself and my team identified some problems with our operation and limiting factors. In the late 90s, we were 5 staff with no clinical engineers and the department head. We were responsible for maintaining equipment at the Children's Hospital and 5 other smaller community hospitals. At that time, we had no input into medical equipment acquisition, and we only provided limited support to high-end technology such as medical imaging or laboratories. And coupled with this, in Canada, we have a huge geographic area with very few population areas with sufficient density to justify a fully comprehensive service that you would normally see at a larger acute care teaching facility, particularly in the US. That's our closest comparator. We had the desire to grow and develop our team and to achieve a vision of a fully comprehensive service from a starting point of being a modest-sized acute care teaching facility. Next. The only viable route that would allow our team to change this goal is we developed a vision that we wanted to become a fully comprehensive service, typically found in your large teaching facilities. The only way for us to do this was to generate revenue from external sources, as much as we'd already done on a much smaller scale with a few community hospitals. Over time, clinical engineering services were marketed from CHEO throughout the eastern region, resulting in healthcare facilities opting into our 14 hospitals, additional hospitals opting into our service, which created revenue generation opportunities. Offering the regional services was a win-win situation for smaller hospitals. They didn't need to manage a 1 or 2 person department and have that liability, or to manage a large number of service contracts or providers. The service was offered at competitive rates, charging more than an in-house person, but substantially less than original equipment manufacturer contract pricing. Revenue generation enabled us to invest in additional staff and equipment and training as well to expand the service offering to all of our clinical partners. Next. From the vision, we developed a long-range plan for improvement. We developed a multi-year 2-pronged plan that included technology and planning and acquisition, as well as expanding the technical support capabilities in all of the clinical environments at CHEO, and then gradually we rolled them out to the other hospitals in the Eastern Ontario region. We started out modestly with reasonable, achievable annual goals, and monitored and adopted new industry best practices as they emerged. When redevelopment projects occurred at our hospital and other hospitals, which required a large volume of equipment purchases and service expansion, we took advantage of this opportunity to add both engineering and technology staff. And to not lose sight on what we were doing, we updated our annual goals, keeping it in line with the long-range plan. We built on our successes patiently over 2 decades, and we never lost focus on one important thing, which was the importance of customer service. Keeping in mind that all of these hospitals participating were doing it on a voluntary basis. Next. We worked gradually over a number of years, implementing our improvement plan. We added specialist teams for imaging, anesthesia, allied health, and laboratory services, and grew these teams over time. We gradually added expansion of service offerings as systems were replaced. This enabled us to establish and develop a technology planning and acquisition service. From that, we developed long-range planning tools and redesigned our process over the next few years with very tangible results. Key to this was the redesigning the capital equipment request process in the hospital and prioritizing requests against several criteria, adding objectivity and impartiality to the entire process. And we developed long-range planning tools, which were used to determine the theoretical annual replacement requirements over a several-year period. Next slide, please. The achieved results. The revenue generation enabled investment in our staff and equipment to expand our service offering to our clinical partners in the region. Over the 2-decade period, we transformed our department's main role from a technical service group, a very good technical service group, to something broader, which was a corporate healthcare technology management service. We now provide service at 20 hospitals at 30 sites in a catchment area of about over 19,000 square kilometers. With a comprehensive role in healthcare technology decision-making process, we are better able to impact healthcare technology management, both at CHEO and throughout our region. Our team has now grown from its humble beginnings to a staffing complement of 6 clinical engineers, including the director, 28 biomedical engineering technologists, and as well as 2 technical team managers. Clinical engineering also stands in a very good position to negotiate new training programs at the same time of equipment purchases, which we couldn't have done earlier on when we first started. Next. This map is just representative of that 19,000 square kilometer area, and it shows you the facilities that we support in the Eastern Ontario region, 20 entities at 30 sites. And one always has to keep in mind, we're working in a public system, but each one of these hospitals are independent and they can make their own decision. They could leave our service if our service was lacking at any time and choose to go in-house or to use a third party. Next. Collateral benefits of establishing this service. Clinical engineering has now been able to offer professional support and specialized training specialized technical support for medical imaging, anesthesia, and laboratories throughout the region. All of these medium to small healthcare facilities in the region now benefit from this resource, normally only found at an acute care, a larger acute care facility. Other collateral benefits including support mechanisms to 2 local university biomedical engineering programs. And we also, our presence along with a few of our colleagues also helped with the establishment of a local graduate CE program, and we've been important in a number of academic research projects affiliated with both universities as well. We've also been able to establish outreach initiatives in the last several years to the developing world and provide equipment and technical support to healthcare in 12 other countries to date. And our department has been recognized both locally, nationally, and internationally for our published work and our achievements. Next. Examples of applied leadership skills that apply to this case study. First of all, innovation. We curbed healthcare technology costs in the Eastern Ontario region while providing increased uptimes and improving support to patient care. We transformed the department's role from a technical service group to a corporate healthcare technology management service. as well, another example is teamwork and goals driven. The technical staff gradually expanded their skills to include medical imaging, laboratory, anesthesia, dialysis, and device development. And the expansion of the regional technical service model has all was done in parallel with the addition of clinical engineering staff. Adaptive decision making. Our program saw steady growth both in our customer base and a tenfold increase in revenue. The revenue generation enabled investment in staff and equipment to the group to expand our service offering to our clinical partners, both at our hospital and in our region. Thank you.